Is oh, thank you. I had to ask you your permission. May I
Yes,
record this talk and
of
host it?
course.
Okay. And so some of our people, they do both ICU service and renal service.
Got it.
So
Yeah.
very, very lucky. So I think it's time to get started. And as you guys may have heard, it is absolutely my pleasure to have Dr. Stevens spend some time with us today. He comes from an institution that's a leader in what really is, physiologic interdependence between kidney and heart. And more we realize over the years that they are, inexorably tied together in a tight matrix. Dr. Stevens trained in internal medicine at Mass General before completing his nephrology fellowship at Columbia, and he stayed on as assistant professor of medicine in the Division of Nephrology. His clinical and renal research interests include critical care nephrology and improving the care provided to patients with AKI. He serves as the medical director of inpatient dialysis and acute care nephrology at Columbia and is also a dedicated medical educator. He serves as the Associate Course Director for Renal Physiology and Pathophysiology at the Med School and as the Associate Program Director for the Columbia University Internal Medicine Residency Program. He's an advisory dean at the Columbia College of Physicians Surgeons Medical School, or I think now it is called Vagelos or Vagelos, right? I
Yes,
think
that's
he
right.
was the CEO of Merck at one time. So
Oh, I didn't know that part, but yes, it's been
he
renamed.
also has funded a dual uh, graduation program at University of Pennsylvania, a much very, very competitive dual graduation 4-year program. Okay, so having said all that, Dr. Stevens, the floor is all yours, and
Great.
please go ahead and tell us about all the interesting things that you're doing at Columbia.
Sure. Yeah. Thank you so much for having me. Really hoping to just share some of our experiences. And while it might seem like a very niche topic of how to build a nephrocardiology service or a cardio-nephrology service, depending on how you look at it, the lessons that we learned and that we continue to sort of benefit from having this combined service, I hope will serve as a template for you as you start thinking about different care models and whether there's an opportunity for multidisciplinary collaboration and really partnership. So if you don't really live in this space day to day, use it for whatever space you interact with, and just take that away from it, not necessarily just the nephrocardiology. But I do know that there are a lot of cardiologists here and a lot of intensivists and maybe even some nephrologists. My disclaimer is that I am not a cardiologist, so I am a nephrologist by training. So I'm going to try to review some cardiology topics, but please correct me if I get any of it wrong. I don't have any relevant financial disclosures. And the basic outline for the talk is really grouped into two different categories. And I think it's useful to break it down into these two groupings, which is, do we have the right patients to have a dedicated service or a sub-service? And do we have the right environment? So sort of the premise and then the challenges. The environment has to be right. There has to be the right buy-in, the right operationalization. And so we'll sort of chunk it into those two major groupings. So first, we must understand that premise. So including the complicated relationship between the heart and the kidney that Dr. Gidwani was referring to, and the challenges of justifying and operationalizing the creation of a new consult service. So here's our checklist that we'll populate as we go through the talk. And it's just sort of how I think about the basic framework for developing any new program. And first, we have to make sure we have the right patients to support that service. And luckily for us, the heart and the kidneys have a very complicated relationship. So I promised everybody that when I put this in for an AI-generated image, I said, please put the heart and the kidneys in balance. Now, even though I said that, to me, it looks like they gave a little bit of extra weight to the kidneys. And they must know some algorithm for who I am to have done it that way. But this is supposed to show that, the goal is to have everyone happy. But the struggle is, as we all know, much more complicated than that. So on the right, you can see our evolving understanding of this complicated relationship between the heart and the kidneys in cardiorenal syndrome. We'll come back to that a little bit later. But hopefully I can convince you in the next few slides that these patients are not only becoming more complex, but they're also living longer with their comorbid diseases. So the number of patients, now I'm just going over a few historical slides to show you the growth of heart failure patients. So the number of patients admitted with cardiogenic shock continues to increase. And importantly, the mortality has remained pretty stable, at least in the period from 2004 to 2014, stable, if not improving over that same time period. So in other words, the prevalence of advanced heart failure is increasing because patients are surviving longer. Let me just put my laser pointer on. So why is this happening? Well, there are a number of reasons, but one of the, I think, most exciting reasons is the great advances in this field of the use of both temporary and durable mechanical circulatory support. So on the left is showing some of the temporary forms used in the ICUs with a balloon pump, Impella, a tandem heart, and VA ECMO. And these devices are meant to be either a bridge to recovery, a bridge to transplant, or a bridge to more durable MCS, the LVAD depicted here on the right. So building on this story, depicting on the left, the figure on the left is really just showing the continued rise in the use of both temporary and durable mechanical circulatory support since 2007. And again, not only is MCS becoming more common, but it's actually becoming more successful in saving patients, demonstrated here by the improved survival in patients with mechanical circulatory support over that same time period. And this survival benefit is seen not only in the short term, which is shown here in purple, but also some of the longer term outcomes at 5 and 10 years, shown in yellow and pink. So you're all doing it right. The cardiologists have figured this out. I wish we had similar curves to show you for nephrology, but our curves don't look like that for ESRD patients. And this allows for more patients to survive long enough to receive their heart transplants. So as discussed earlier, so this is just showing you the overall number of heart transplants is increasing over time. And as I discussed earlier and shown here in green on the right, the use of LVAD, durable mechanical circulatory support, as a bridge to transplant has become increasingly more common since 2007. Despite the complexity of these patients, heart transplant recipients are also living longer, as shown here with a decreasing mortality rate, with the longest time period observed showing the greatest decrease in mortality here in brown, which is 10 years. But these heart transplant recipients who are living longer do have more accelerated declines in their GFR. So if you're not a transplant recipient, you don't have baseline CKD, and you develop this, you have an insulting trigger, and then you have acute kidney injury, your chances of recovery overall are pretty good, with only a minority going on to develop either CKD or ESRD. But in non-renal organ recipients with higher comorbidities at baseline and unique pre-transplant insults, there is actually a lot less functional renal reserve. And with ongoing insults from the CNIs, from the mTOR inhibitors, the post-op period, they often have a less complete recovery of their kidney injury. And this results in a higher progression of that acute kidney injury into what we call acute kidney disease, which is that period where they're in this window of recoverability, but not really established CKD. And then they have a higher incidence of CKD and of ESRD. So you can see here, your chances of leaving normal with normal GFR is much, much lower if you have a solid organ transplant. And the figure on the right demonstrates just how common advanced CKD is in this population, with years from transplant on the x-axis, and approximately 15% of patients will have a 50% reduction, let me see here, 50% reduction at 1 year. So at 1 year, right here is about 50% reduction in GFR. And of the survivors, approximately 15% will, of heart transplant recipients will be ESRD by 10 years out from their transplant. So we're not talking about small numbers, those pretty large numbers. And this trend is not only true for patients with heart failure who received a transplant, but in fact, all patients with heart failure who are living with more comorbid conditions, including CKD, which is just shown here in this lightish gray. And so the period from 2002 to 2014 shows that comorbid chronic kidney disease in heart failure patients has increased from less than 5% before to now 24%. When it was last reported back in 2014 from this study, it's even higher now. And so heart failure patients are becoming more prevalent. They are receiving higher rates of mechanical circulatory support as a bridge, and they're receiving more transplants and living longer with more accelerated CKD. So I think I've painted the picture for how this comorbid CKD and heart failure is becoming more and more common. But we have to also consider the high volume of patients who receive cardiac surgery who then go on to develop acute kidney injury. And this is shown in a few different ways in these figures. This is a study looking from 1993 to 2002. And they said, how common is acute kidney injury requiring dialysis? How common is kidney injury where there's a 50% drop in GFR? And how common is a combination of either of those two outcomes? And they divided it into these two different periods to see if it's changing over time, with the black bars representing the patients that died and the gray bars representing patients who survived. And you can see while the cardiac surgeries overall are increasing in volume, there's still a pretty high mortality. So 49% in the later period still died in the hospital if you had AKI requiring dialysis in that period. And I think it's a pretty humbling graph to remind ourselves of, is that, you know, if you have acute kidney injury requiring new dialysis in the hospital, this is in line with large studies, large national studies, large international studies, citing in-hospital mortality upwards of 50%. So this is not an insignificant event if someone's starting on dialysis. Of the patients who go on to survive, many convert their acute kidney injury into acute kidney disease and CKD after surgery, similar to what I showed you for the heart transplant population. And 60 to 75% of them will go on to develop progressive CKD, which just highlights the significant morbidity of the survivor. So it's not enough just to, it's not enough to survive. Even if you survive, you're up against a pretty big climb there if you develop this progressive CKD. And this represents a group of patients that we all take care of in the hospital and sometimes out of the hospital. And the transitions when they go to our clinic is another very vulnerable period. So we'll touch on that a little bit later too. So the premise, we're finishing with the premise, that first chunk. I hopefully have shown you or convinced you that the incidence of heart failure and cardiogenic shock is increasing. And the prevalence is also increasing due to some newer therapies or advances in therapies, which is increasing the burden of comorbidity with kidney disease and increasing complexity of those procedures and interventions, all leading to increased rates of acute kidney injury or increased volume of acute kidney injury. And so caring for these patients requires, a very subspecialized set of knowledge of these advanced therapies that are becoming more and more available to patients that we take care of. And so what does it look like for a patient mix on a cardiology or a cardiac surgery service? How involved is nephrology? How often are cardiologists and nephrologists talking? And so we start to think about, well, what really would it take to have a specialized group? Like what knowledge is actually unique here? What subset of specialized knowledge or procedural skills might we need? So I've grouped them into three different categories of what I think of as core set of knowledge that any nephrologist caring for patients like this should be aware of at least. Everyone talks about POCUS. I won't belabor the point that POCUS does have clinical utility in a service thinking about taking care of comorbid kidney and cardiology patients. An understanding of mechanical circulatory support, understanding some of the nuances of managing hyponatremia and heart failure, a pretty firm understanding of RV failure and pulmonary hypertension and the complicated role of increased venous congestion in those two physiologic states. Advanced diuresis hopefully is common knowledge amongst all nephrologists. And then the cardiorenal pathophysiology that I was referring to earlier, we'll get back to that one. Actually, we'll go right now. Our understanding of the pathophysiology, and this is the only slide I'll talk about for physiology, despite me wanting to talk more about it, but our understanding has really grown in this area, and it's advanced quite rapidly. It's no longer just seen as a condition of renal failure that's precipitated by cardiogenic shock and poor forward flow, which I think was the classic teaching before there was a better understanding of all these other additional pathways and mechanisms for why you might see worsening renal function in the setting of heart failure. And so the nuances and multifactorial contributions have really led to more tailored interventions to get someone out of cardiorenal syndrome. For example, we now know that having an elevated filling pressure and a high CVP is actually more predictive, even compared to cardiac index in predicting the development of cardiorenal syndrome. So that's just shown here with these area under the receiver operator curves. Red is depicting CVP as a predictor of worsening renal function during that admission, whereas cardiac index is green, close to the line of identity. So there's a much better performance and sort of building a case for the role that these increased venous pressures play in the development of worsening renal function. So there are additional autocrine, paracrine, endocrine contributions, and each arrow in this complicated figure has specific interventions that warrant consideration when we take care of these patients. So this slide didn't exist probably 20 years ago, right? Where it was just thought of as low output state, no blood to the kidney. And there's a lot that we can do for patients like this now. What about some of the procedural or operative specialized knowledge? Well, we often get consulted for CIN risk assessment or mitigation, for perioperative AKI risk assessment. There's a sort of multi-pronged AKI after cardiac surgery sub-work groups that have been formed at Columbia to try to tackle this problem. There are understanding the kidney outcomes after cardiac surgery, kidney outcomes after heart transplant, and an understanding of dual kidney heart transplant. So operational workflows, how do we provide RRT while someone's on the cardiopulmonary bypass machine, which we'll talk about soon. What happens when the kidney is going in and the heart's already in? Do we switch over to CRT? So there are a lot of operational processes to work through in order to really support a robust nephrocardiology program. The thinking about that perioperative AKI, which I briefly mentioned before, there is the subspecialized knowledge set, and a lot of the pathophysiologic factors that lead to acute renal failure in the preoperative setting are probably ones that we would all think of. But there are specific intraoperative insults related to being on cardiopulmonary bypass, which, if you've not seen cardiopulmonary bypass before, is a very intimidating circuit. So even for someone who likes dialysis, the first time I saw this in person, I was very intimidated, and it's very complicated. But it's not hard to imagine that exposure to these non-biological membranes can result in a cascade of inflammatory cytokine release and subsequent kidney injury, which is separate from the hemodynamic ischemic insults and hemolysis-induced oxidative injury. So showing you here on the right is a spline graph, just demonstrating the relationship between cardiopulmonary bypass time and risk of acute kidney injury, with 50% of patients who are on prolonged bypass developing acute kidney injury. So that's a huge risk. And unless you understand that body of literature, if you're trying to piece together what happened in the OR, you don't see any documented hypotension. I think it takes this understanding of, doesn't really matter what the hemodynamics were, there are lots of other factors that can lead to the development of renal failure in these complicated cases. And then finally, the postoperative period, when we usually meet them, is riddled with ongoing insults of cardiogenic shock, distributive shock, continuation of nephrotoxins without meaning to, and the list goes on and on. Finally, this last group, how do we provide RRT to patients during their critical illness and in transitioning those cares? What's the best approach for providing RRT in the OR, this perioperative planning, this intra-op RRT delivery, and alternative CRT, and we'll come back to that at towards the end. I saved that big one for a different part of the talk. But even things like alternative CRT configurations with ECMO, right? You have someone on ECMO, they have limited access, they've got stents in their subclavian, whatever it is. If you have limited access and you're now thinking about, should I hook up the CRT circuit to ECMO? Is anyone on the call who wants to chime in here? Do you practice this at Sinai? Does anyone do parallel CRT in the ECMO circuit? Everyone's shy.
Yes, we do.
Oh, you do? Okay. So, this is becoming more and more common, I think, as there are more patients with more complicated access. So just as one example, there's a nice review here that I'll include in case anyone wants to read it. It's getting a little bit outdated now. It's from 2012, and they were still describing these ECMO roller pump circuits. Back then, the more common configuration was to put everything pre-pump, right? So you put the inflow for CRT and the outflow for CRT, the inflow and the outflow both before the pump. But I would argue that as the centrifugal configurations of the oxygenator and pump combos have become more common, our practice is to actually put the CRT inlet line originating from the post oxygenator segment and the CRT outlet line, or the return line, going to the pre-oxygenator segment to have opposite pressures, right? So you want to be applying a negative pressure when you are experiencing a positive pressure. You want to be applying a positive pressure when you're experiencing a negative pressure to try and minimize air entrainment. So again, understanding that there are different options and different configurations, I would say for a nephrologist is knowledge that's not accessible de novo. It's not like we all trained at institutions that did this routinely. What about LVAD and access maturation? So this is just another quick example of when we we're just looking at the feasibility of, we're always taught not to place AVGs and AVFs in patients with LVADs, but we actually partnered with cardiology and vascular surgery here, and we described this case series of 3 successful patients with LVADs where we were able to use their AV grafts after placement. And so it just shows another example of this collaboration between cardiology, vascular surgery, and us to try and really think about what might be best for this patient in terms of risk of infection, balancing that out with the risk of non-maturation of an AV graft or non-healing of an AV graft. And finally, to finish off this section of the advanced RRT, how do you actually perform dialysis in patients with an LVAD? It's not so easy. It's not as straightforward as performing dialysis in someone without an LVAD, and many of them have this incredibly narrow pulse pressure, and baseline systolic blood pressure is less than 90. We're often starting with those sort of baseline parameters, and then how do our nurses know how much ultrafiltration would the goal be? How much are they tolerating? Which parameters should they be following to guide that ultrafiltration goal? And so having an understanding of the LVAD parameters displayed on the system monitor is really crucial. And so our nurses get trained on this, including the pulsatility index, which is really just a representation of the magnitude of the flow pulse, and during, through the LVAD during systole. So changes to the pulsatility index during dialysis can really herald circulatory collapse, and LVAD alarms that the nurse needs to really be tuned into and well versed to start following these non-traditional parameters for guiding ultrafiltration when they're performing dialysis on these types of patients. This is a great review, by the way, if you're looking for one. Okay, I think we're finishing up this section too. So these are the three buckets that I think of what does a nephrologist need to know that subspecialists like cardiologists, like CT surgeons, like CT anesthesiologists probably already have access to that information. This is sort of the list of requirements that I think we would have to do our homework on to get up to speed in order to start thinking about having a very specialized service. Okay, so that premise is true. Our patients are sick. And this notion is of nephrocardiology or cardionephrology, depending on how you look at it, is really here to stay. So I just did a quick search in the literature in PubMed about nephrocardiology and cardionephrology, and it's becoming more and more common. So it is here to stay, but does it make sense for you to have a specific nephrocardiology consult service at your hospital? So now we'll just explore some of the challenges of implementing a dedicated service. All right. So before we do that, we're just going to spend a few slides for you to understand what our consult services look like at Columbia, in order for you to see why it makes sense for us to have a dedicated service, and you can start thinking about whether it makes sense for you to have your own service. And I initially gave this talk at the American Society of Nephrology, so not everyone knows where we are, but I think everyone on the call knows where we are. We're just not too far away, maybe a couple miles. About a 750 bed hospital. We have a high number of ICU beds, 28 CCU, 31 CT ICU. And I'll show you some data to support this later, but pretty high volume of admissions of either CCU or CT ICU admissions. And there are 4 dedicated cardiac surgical ORs with overflow, like other ORs being used as overflow for high volume days. And over 2,200 heart cases were performed last year, and more than 1,000 of them were on bypass. Those, over 1,000 on bypass, this is data that's a little bit old now from 2021, but it's a pretty wide mix of, it's a pretty great mix of isolated CABG, isolated valve, aortic cases, heart transplant, VAD cases, congenital. And so it's a good mix and representation. This high volume of those procedures really populates the cardiac ICUs, and they get an average of 8 admissions a day. This is just showing you data of what happens annually for our ICUs. This is combining all the medical, combining just the pure surgical, neuro ICU, combining all the CCUs, and combining the CT ICUs. And like I said, in this year that I think this was 2022 that I pulled the data from, there were over 2,500 admissions. And nearly 40% of all the admissions are really coming from our 5th floor. So we are regionalized, we're geolocalized to the 5th floor, which is very helpful, which we'll come back to later. Just to fill you in quickly on our CRT program, we're a high volume program. We have 700 patients per year on average, with 6,800 CRT patient days per year. And so that translates into roughly 18 to 20 patients on CRT for any given calendar day. We recently had a max during flu season of 33 patients in a single day, which I'm having flashbacks to COVID again when we get up that high. And the average duration of patients is 10 days with an in-hospital mortality of about 43%. That in-hospital mortality is a little misleading because it includes both ESRD and AKI. So it's all of our CRT treatments. So how do we break down our services? This is for our nephrology services. We have these are for the non-primary team services. So these are all consultative services. We have general consults. We have what I'm going to show you which is nephrocardiology. We have an ICU CRT service, which is all the non-cardiac patients. We have our dialysis service. We have a transplant consult service in addition to a transplant primary service. And then we have a smaller hospital that we have just a general consult service where it's a mix of ICU, CRT, ESRD, HD, and regular consults. This is data going back to 2020 till now, and it's just showing you the average list census for each of those services. And I've highlighted in green here our dedicated nephrocardiology service to show you sort of what we're up against. So if we didn't have, well, let's just take it step by step. If we're just talking about non-transplant services, so general nephrology consult services, we average about 100 patients on our combined lists in a single day. So I think it's anyone who is a consultant on the call can understand how busy that can get. And so we really needed to have many different consult services. And the idea that our fifth floor is geolocalized is very attractive for having a natural break into having a dedicated service. So what I want to highlight here is that on average, we have about 17 to 19 patients on our list. And if you try to add that onto consults, which is shown in red, you're easily getting up into the 40 range for your consult service. So it was really necessary to break these down. And so part of it is just out of necessity. We have to have smaller services because otherwise all the fellows will continue to like not want to go into nephrology, which we already have that problem. And so on any given year, we typically receive about 400 to 500 new consults for the nephrocardiology service. And so if you're trying to explore whether you have the volume to justify forming this dedicated service, I would think that you'd start by working with your reporting team or data analytics team to really pull the consult volume of your consult services to figure out which of these patients are actually on cardiology services versus non-cardiology services as a first step. I imagine you probably have the volume because you're a very busy cardiac hospital. This is just showing you again that while 18 is the mean over this period, it can sometimes be as light as 5. I think all the CT surgeons went on vacation together somewhere for that week, but sometimes we get up as high as 31. So it can be a busy service at the peaks, but sometimes it can be underutilized. But on average, we're about 18. So after seeing these numbers, hopefully it's not too hard to understand why our fifth floor volume is sufficient to support that dedicated service. And really working with your local EHR group or clinical leadership group for EPIC is that first step to figure that out. And so now we're going to shift into thinking, is there multidisciplinary and hospital or institutional interest? Which the fact that I'm giving this talk, hopefully the answer is yes. And if you aren't familiar with Dr. Flecken, I highly recommend that you check him out. He was actually a year ahead of me in med school at Dartmouth. He was in my wife's class. And he does a really brilliant job at portraying these classic cardiology versus nephrology stereotypes, which really culminates in a couples counseling session, which is shown here. And it's gone viral. So if you haven't, it's really fun to like poke fun at ourselves. So I highly recommend you watch his skits. But luckily for us, the relationship between nephrology and cardiology at Columbia is often much warmer than the situation that he depicts. And because our service has existed for almost 18 years now, most attendings don't know any other model. And certainly I came after it was already formed. So instead of pretending, that we formed this new, it's been here for 18 years. So I instead went around and just asked different attendings what they thought of the model and whether they thought it was working well or not working well. And these are just some of the testimonials from them, staying in sync with our nephrology colleagues, We can learn from each other, heart failure attending, shared goals for improving processes, which is one of the anesthesiologists who runs the CTICU, very helpful and accommodating. I'll point out the CT surgeon was the shortest response. They were in a rush. And then I think really some patient populations that we don't always remember, but really would benefit from having this subspecialized knowledge is those patients with congenital heart disease, right? Discussions about chances of renal recovery, goals of care. What would being on dialysis look like for a patient with congenital heart disease? So these are circumstances that come up very commonly on our dedicated service, but if it was diluted out across 4 different non-specialized services, you wouldn't really be as comfortable with these specific scenarios. Now I'm going to spend a few slides before we end here going over an example of some of the benefits of forming those close relationships with colleagues from different disciplines. And by having this dedicated service, we staff our service with 13 of our 33 attending. So only 13 of us attend on this particular consult service. And that really allows everyone to get to know each other better and to form these collaboration teams. And so this is one example where we were in a situation when I was a fellow where we were wasting a lot of resources for performing intraoperative hemodialysis for cardiac surgical cases for ESRD patients. And we really thought it is time for us to revamp this process. And before I get started on this, can someone just chime in? Does anyone know for patients who are undergoing cardiopulmonary bypass at Sinai who are ESRD, do they get any form of intraoperative renal replacement therapy? And if you don't know, that's fine too. Any nephrologists that I can pick on? No? Okay. So I'll just share our experience, and then you can go back to your teams and figure out what they do at Sinai, because a lot of these processes are sort of internalized within the perfusion teams and the CT anesthesiology teams. And so this is our adventure of revamping that whole process, which again, I think was so successful because we all knew each other already, and because we weren't just strangers that see each other 1 or 2 weeks a year. We really, on a day-to-day basis, see each other rounding. So I'm not going to get too far into the details here, other than to say when patients go on cardiopulmonary bypass, they're given a high potassium concentration of cardioplegia to stop the heart, and it's diastolic arrest in order for the surgeon to perform the procedure. And then at the end of the case, they need the potassium to be normal again to restart the heart. And you can imagine the problem here with our dialysis patients who cannot clear the potassium by peeing it out. And so without having a way of taking the potassium back out of the body, they remain in diastolic standstill. And surgeons don't typically like that because then they have to crash them onto ECMO in order to leave the OR. So we historically used to provide hemodialysis in the OR, which is a very cumbersome and sort of operationally clunky thing to coordinate with a operating team and a very confined space. So instead we said, okay, this has been well described in the literature, this concept of zero balance ultrafiltration, which is essentially just hooking up what looks like a dialysis filter, which the perfusionists call a hemoconcentrator, into the cardiopulmonary bypass pump circuit and utilizing that to remove fluid. And then we use the CRT solutions to give the fluid back. So it's zero balance because we're rinsing and wringing the blood. We're performing CVVH. It's just a fancy, it's sort of a bootleg version of CVVH without needing a CRT machine. So the perfusionists run this protocol now that we developed, and it's a weight-based protocol, and it's really allowed them to, oh, sorry, I just realized now you couldn't see that filter. This is the small little filter that they call a hemoconcentrator that any nephrologist would call a dialyzer. And it removes fluid, and then we give fluid back. And so we developed this algorithm of checking every 15 minutes in the OR. They have these epochs that they check, or iStats. And depending what the potassium is, and depending on how many times, what range it's been in, and what their weight is, it really guides the perfusion team for delivering certain volumes of this replacement fluid. And it gives guidance of when they should be calling us if it's not going well. This has really transformed our our dialysis operations in the hospital. So this is when I was a fellow. This is when we went live with the program. And since its adoption in 2018, it's really not only replaced intraoperative hemodialysis, but it's allowed for a growth of the program of the types of procedures they're performing on our dialysis patients. And so last year, there were 80 cases where intraoperative Z-Buff was used. Some of you might be wondering, well, does it actually control the potassium? It does. I won't get into the details. This was the first 20 patients in the pilot phase. This is when you perform the zero balance ultrafiltration. You can see the potassium expectedly goes up, but then it's controlled by the end of the case. So I think it goes to show that it's just one of the many examples of sort of already having that buy-in, that multidisciplinary buy-in for starting a new protocol, if you already have some long-term relationships built out with that smaller set of attending. So it really gets rid of that anonymity that you can sometimes be a part of in a large academic place like Columbia or Sinai. Okay, so finally, once you establish that there's a local interest and to forming a service, I think the greatest challenge, which you can all appreciate, is how do you actually operationalize that? Luckily for me, Jay Radhakrishnan is way older and much wiser than I am. And he formed this service way back, like I said, about 18 years ago. So the heavy lifting was done by Jay Radhakrishnan. Anyone, and I know Dr. Gadwani knows him well, but anyone who knows him will understand that it's not a joke that some of our cardiologists say that Jay Radhakrishnan is the smartest cardiologist in the hospital, even though he's our clinical director of nephrology. And so in response to a growing consult volume that he was seeing and an increasing complexity of patients, it really was coinciding with a time when the hospital geolocalized our cardiac services all to the 5th floor of our hospital. And that's when he thought, hey, this is the right time to try this out. So due to that popularity and growth of the service, since that time, there's now a dedicated fellowship spot. So the fellowship was expanded by a fellow. And for over 12 years now, there's been a dedicated nephrocardiology fellow, which is one of the fellows' rotations for general nephrology fellowship. It's staffed, like I said, by about 12 or 13 of our 33 nephrology faculty. And the fellows get to be on that service on average between 10 and 16 weeks of their fellowship, depending on if they want more or less time on that service. We often have a lot of other trainees join us from, anesthesiology, critical care fellows, residents, medical students. And I already mentioned the high volume of consults on that service. And while this particular model works well in our hospital, and I think it would work well in a large hospital like yours, it might not necessarily be the right model for every hospital. And I think that's pretty obvious, but it really depends on the anticipated consult volume and the potential for geolocalization. Because you can imagine if you start forming a nephrocardiology or cardionephrology consult team, but it's not geolocalized, then a team has to say, oh, I'm consulting them about contrast nephropathy risk assessment. That's nephrocardiology. Or if I'm thinking it's cardiorenal syndrome, do I consult nephrocardiology? So I think if it's not geolocalized, it leaves too much up to interpretation, unless you have sort of a triage consult fellow where they're sort of getting all the consults and diverting them to the right teams. That could still work if that's the way that you handle consults. How to staff. So each new service is really dictated by the volume, and busy services would need a dedicated attending and fellow. At Columbia, because it's such a busy service, we have protected clinical time when we're on service to facilitate more rapid consult staffing. So often these patients are very sick. We don't have the luxury of waiting 6 hours when they're out of clinic and coming around for PM rounds. So we really have a subset of attendings that allows for us to protect the clinics during that time. And by having only a subgroup of those attendings, it really allows for that professional development, for those connections to be made. And we already saw some of the benefits of that more frequent and consistent interaction with cardiac services. Just some other considerations and other aspects as you form if you decide to form your own. But other topics that have come up is, should we be co-rounding? Should there be an integrated rounding model? And I think even if you can't do that, which our service is so large, actually, to round with 4 different ICU teams on 20 different patients is pretty hard to do. We at least aim to have ultrafiltration rounds where we run the list of saying, okay, here are the 5 we have in the CTICU. Let's go over our goals. Like, we were thinking -2 liters in the next 24 hours. Great, we're on the same page. So quickly running through the list with the CTICU fellow or attending is sort of our goal and our standard that we hope to do with each day that we're on service. There's this real-time rounding that happens where I was recently on service. There were 3 different services having 3 different ultrafiltration goals. The CTICU primary thought one thing, heart failure thought another thing, we thought another. So we all met at the bedside. We ran a fresh set of hemodynamics, and we kind of came to a consensus about what the new ultrafiltration goal should be. So that's the sort of environment that can exist when you're only on one floor. You can sort of run to the bedside and check in on patients. There are these obvious opportunities, I think, for teaching and advancing research. There are tons of quality improvement and patient safety projects that can be born out of the creation of having a dedicated service. And then longer term, there's a consideration for what happens to these patients when they leave the hospital, right? We have a dedicated inpatient service. When they leave, are they going to be seen by a general nephrology clinic session? Is there going to be a dedicated nephrocardiology clinic? Is there going to be a combined multidisciplinary clinic where cardiology sees them and nephrology sees them? These are all possibilities. Okay, so I know I didn't go over every last detail, and we hit broad strokes, but I do want to leave you with this more detailed list of, thinking back, if I were trying to start this again, what are some of the considerations that I would have to work through, not only for building a nephrocardiology service, but I think for building or imagining any new service where it's a subspecialized group of patients that you're trying to take care of. And we talked a lot about the first 3, but just spending a little bit more time here, right? So the steps. Is it going to be a primary teaching service? Do I need to involve fellows and trainees? What are their other responsibilities? Should I be thinking about creating a separate consult order and a separate EHR list? How do I disseminate that this is actually happening with the cardiac teams, posting job aids, and then really thinking about that next phase, right? So if you decide to form a new service, what will you measure? Is growth and the census volume enough to justify success? Should you be thinking about, if you do decide to form a dedicated service, you have a great opportunity here because, you can have a pre-implementation period where you measure certain outcomes of your cardiac nephrology patients. And then if you implement a service, you could actually do that post and compare. We're too far into it to be able to do that. But I think being really thoughtful, if you decide to take the leap and reimagine the structure of your nephrology consult services, it would be a great opportunity to really get that baseline data before starting the implementation of a dedicated service. I think that's all I had planned. I can field questions and talk more if people want me to talk more, but I'll stop there for now.
Thank you so much for this very high-level review of what you guys do. And I'll tell you that we are not dissimilar in obviously the volume, the type of patients, and clearly the complexity of work that we see. We do not have a cardio-nephrology service per se, but we have an ICU nephrology service, and I think they do a fantastic job, though obviously you can always build out your competencies, the deeper you go, the more focused you are. So fascinating talk, a great, program by Jay that you are building, on top of. Now, do you know amongst tertiary and quaternary care centers, how many centers have such a dedicated nephrocardiology program?
Yeah, I don't have the exact number, but I have a sense that it's not as common as it probably should be. So as far as we can tell, there was a recent, I can send along, there was an AHA podcast that we did last year with there are three centers that we are aware of that have similar models. So Northwell has a model like this now that went live, I think in 2000. I want to say in the last few years. I'm not sure the exact age of that program, but this podcast and this review article, it sort of goes over the history of each of the three programs. And then University of Washington has a dedicated nephrocardiology program. And then we happen to be the oldest because of Jay. He formed it like 18 years ago. So it's the other two programs I think have launched in the last 5 to 7 years. So it's a fairly new concept. It's not like most medical centers have a dedicated nephrocardiology service. I would say it's still quite rare. There might be a couple others that we just didn't that we weren't aware of, but it's certainly under 10 across the country.
Great, thank you.
Yeah,
I see that you finally got your AI image creator to get the heart and the kidney at the same level, though the kidney
exactly.
seems to have nephromegaly or
Yes.
nephron.
Yeah, it didn't quite get the glomeruli right, but that's
Okay.
okay.
I open it now to questions from the audience. We have at least maybe one or two nephrologists on the call. Any questions for Dr. Stevens, guys?
Hi, Dr. Stevens. I joined late. I'm on night shift, so apologies. But I just wanted to thank you for the talk. I have a nephrology background. I don't actually get to practice any nephrology anymore, but it was very interesting to hear about what you've done in Colombia. So I appreciate your time coming here and speaking about what you do.
Absolutely, no problem.
Excellent. Anyone else? I don't want to hog up all the time. So, Dr. Stevens, let me ask you a question. So,
Sure.
obviously we deal a lot with, uh, the cardiorenal syndrome. And as you know, there are lumpers and there are splitters, and I'm one of the lumpers that, that figures that um, there are bidirectional pathways with, venous congestion being a really important determinant of worsening renal function. Having said that, we are quite liberal in using ultrafiltration, and sometimes there is somewhat of a discordant view with my group trying to usually stop the diuretics when we are ultrafiltering with the hope that all the mechanisms that lead to the upregulation of the mechanisms that cause diuretic resistance will reverse, the organic anion transporter, pendrin, and all these kinds of things. So do you guys have a standardized approach to what you do with diuretics once the patient is on ultrafiltration, specifically for cardiorenal syndrome or heart failure derived renal failure?
Yeah, we don't, and actually, as a full disclaimer, we don't do scuff at Columbia. So I think there was a period before I arrived where they were using scuff, that like CHF Solutions or Aquadex, but we don't do that anymore. So we do ultrafiltration, but usually there are other indications for clearance. So I'll tell you as much as I can for once we start CRT and we're performing ultrafiltration in sort of pharmacologic refractory overload, we don't have a set protocol for what to do with diuretics. Many of us say, hey, we know we can control this minute by minute on this machine. that's much better than any guess of what the right dose of diuretics might be. I know there's the dose trial, which gives guidance overall of what to do for drip versus bolus, but I often find myself more in the load and then drip bucket for those very fragile patients where you're trying to be very mindful of not ramping up sympathetic surge from over diuresing for a couple hours and then under diuresing for the rest of the time. So I hear what you're saying, and it's not as if we say once we start CRT, let's continue and let's do 100 BID of IV, Lasix. We don't have that approach, and we don't have a protocol. And I would say probably 95% of the time we're discontinuing diuretics.
Yeah. I mean, the reason I'm asking this is there isn't great evidence. And the dose HF, Felker himself, I think, is a little bit of a convert towards, there was a complicated study, 2x2 factorial, dose versus bolus, high versus low, and really didn't show a difference. But we won't go to the details. The reason I'm talking about ultrafiltration is because from a resource utilization perspective, it is significantly less, cumbersome, and often leads to improvement in renal function and restoring or restoring diuretic responsiveness, reversing diuretic resistance. So I was wondering why you don't use it, because to me, I think that should be the first line. The first line before initiating hemodialytic therapy should be ultrafiltration therapy to see if we can actually pair. Now, obviously, there are studies looking at early versus late, so we won't go into that. But obviously, we practice in the opposite, realm. In any case, it's 2 o'clock. I don't want, we have another meeting now, but
Sure.
any last words, if you wish, please go ahead. And we're going to have you back because this was too broad a topic to do justice with. So
I know.
More focused. Yeah.
Yeah, it's hard. Yeah, it's hard to. Sometimes it's even harder to give those talks. So yeah, happy to come back, and thank you so much for having me. And my email's here if anyone has any ideas or questions or want to collaborate. Just feel free to email. Thank you so much.
Finally, Columbia has emails that correspond to names as opposed to numbers and these initials.
You know what? It's still the same system as before, but you're allowed to create aliases now if it's your name. So I just sort of did that, but my actual email is still the code. Yeah.
All right. Thank you, my friend.
Easier to remember this one.
Okay, this is easy. Thank you so much.
Okay, thank you.
Take care.
Bye.